The term population health management can come across as the latest kind of think piece and something that might put the front line off. Teams in acute hospitals and in primary care and throughout the system need to think of this as a series of capabilities and techniques, and develop the right terminology for them. But actually, this is about looking at the data and making incremental change for patients that supports them to manage their own health better and ultimately have better outcomes. We have a lot to learn from other industries who are using data, using large sets of data to improve their operations and improve their management of their customers in many different ways, and their support to their customers. And at the moment, our predominant use of data in the NHS is to report on what has happened. And we have the potential to use the data on what has happened to help us plan for what is going to happen and to help support patients to avoid it happening in the first place. And we have that potential.
We've got a lot of analysts in our system, and they often didn't speak to each other. They often referred to feeding the beast, doing lots of reports for reasons which were probably very good reasons, but the analysts themselves weren't entirely aware of why they were doing them. And they had this idea of this big faceless beast that they were just doing reports for.
And what we need to do is actually build up the skill base and the capabilities of those analysts, but then link those analysts to now the actual clinical directors of the primary care networks, but also linking those individuals to our management structures. We had that pyramid going forward. We have analysts, you have the management and this governance structure, and then you have the clinicians. And the key thing is that actually you need to get the three of them coming together, because that's where you get that really good working relationship. And when you get the three of them together with the basis of the data, where you can interrogate that data, that's where you get the real transformational changes.
We had a CQC report on the Reading local authority and across the whole health and social network together. And one of the key points of concern raised was the higher number compared to the national average of patients attending A&E in the over 65 age cohort. We've been trying to do various projects to address it, but the arrival of population health management kind of gave us a good steer in trying to get a regression analysis and trying to see how we can identify those patients before they are going to attend the A&E, rather than deal with those patients who have already attended A&E many times. Because what we were getting to date was retrospective data, and for the first time we had prospective analysis to identify this cohort of patients, working out how many housebound patients I have on my list and how much we are currently spending on them per year. And as we looked at the regression analysis, and we have about 20,000 odd patients who are over 65 in the Reading as a population, out of which I think 2,300 and something patients are housebound. And that is where I think many of the cynics were won over, because we were able to present them with data of patients who are most likely to go into A&E, for example, and put in proactive health management to tackle those patients before a catastrophe were to happen.
Part of the problem we've had previously is that there's a lot of data in our system, a huge amount of data, and it's quite messy. So I'm not going to promise that it's a perfect panacea of everything. It's highly complex. And often I will have been in CCG meetings, and we will be trying to work out what that data actually means. And it's quite easy for us to say, well, we're not quite sure what it means. Is that true data? We're not sure if the measurement's done. Let's send it back to the analysts with a question and meet again in a month's time at our next committee meeting and go from there. Now, I'm not saying that that's the wrong approach, and it's very suitable for certain things, but for population health management, which is done on a lot more of a local level, actually having that link with the analyst, that personal link, you're picking up the phone and talking to them. So by having that personal link with the analyst, we can do things a lot quicker. We can get an honest conversation about what the data can show us. We can start seeing if we can see patterns, whether the complex analysis can identify patterns, whether that holds true with what we're seeing on the ground. So it's coupling that complex analysis with our clinical experience and day-to-day experience of what is happening within our system and within our working lives.
We identified that this is a cohort that is vulnerable. So my project was to come up with a solution which was a practice nurse who would not normally go out to visit patients, normally would only see the patients who come to us, but an extra time to go out and see these patients. So we narrowed the housebound patients down to those with long-term conditions, because again, that was one of the things that was pointed out in the regression analysis, that patients who have COPD and who are housebound, patients who have diabetes and dementia, and those who are housebound, they are at a higher risk of a non-elective admission. So then they have their chronic disease reviews at their own home. They have a care plan, anticipatory care plan, telling us what we should be trying to prevent, what we should be anticipating in terms of if they had a crisis and they were to call a paramedic, what would the paramedic need to know about that particular patient to help them form a decision as to whether this patient needs to be transported to A&E, or is there a better alternative available for that patient.
The real positive is definitely the energy. The real positive in the programme is definitely the energy of the 3 or 4 practice leaders who had taken their data, looked at their patients, felt they could do something different, and then actually brought that to fruition. And when they're reporting that back about how they've changed their own ways of working and ways of thinking about use of data and intelligence to support their patients better, that's definitely the difference. And seeing that be a team journey, a multidisciplinary team journey between an acute physician in the trust and a GP in the local area, and actually they're doing something different to support patients better, I think that's the real positive from the programme.